Welcome to the redsaree webinar series. For those of you who do not know me, I'm Charles Thodeti, Associate Professor at NeoMed. I'm also the President of the Akron chapter of redsaree. So redsaree is a non-profit organization that promotes healthcare awareness amongst the South Asian community. So I'd like to thank redsaree and the founder, Dr. Shekhavil Sarayappan, for giving the Akron chapter this opportunity to host the webinar. I'll be moderating today's session. Before introducing today's speaker, I would like to remind everyone of some housekeeping rules. Number one, all participants except the speaker is muted. Also, please keep your devices on mute. The presentation is streaming online and recorded. The duration of the presentation is 60 minutes, 30 minutes talk, and 30 minutes question and answers. The Q&A will start after the presentation. Please post your questions on the chat. I will read off the questions to the speaker on your behalf. Okay, so now it's my greatest pleasure to introduce today's speaker, Dr. Vinayak Hegde. Dr. Hegde is the resident cardiologist and director of cardiac imaging at the Akron General and Cleveland Clinic Hospital. He obtained his MD from India and then completed both his residency and fellowship in Western Pennsylvania in US. He joined as a cardiologist in Akron General Hospital in 2010 and rose through the ranks to become the director of cardiac imaging. He is also clinical associate professor at NeoMed, where I work. He is well liked by both patients and students. So he received Best Teacher Award 3 times from NeoMed, 2010, 13, and 2017. He is also an elected fellow of the American College of Cardiology. Surprisingly, I found that he has authored around 18 publications, which shows his interest and passion for research. So without further ado, I'm pleased to invite Dr. Hegde to deliver his lecture. Dr. Hegde.
Thank you, Charles. Thanks for the kind introduction. Okay. All right, so let me start by sharing my screen here. All right. Hope everybody can see my screen now.
Yes, it's good.
Okay, great. So we'll get started with the talk now, guys.
Yes.
It's titled Cardiovascular Risk Assessment and Management in South Asians. So this is the outline of the talk. Today we'll be talking a lot about risk factors. There are different risk factors. We'll start off this talk with lipids. We'll then talk about some lipoproteins that are atherogenic. No talk is complete without talking about obesity and metabolic syndrome. We'll talk about some diet and supplements that are important in this day and age. Then we'll talk about putting it all together and trying to assess somebody's risk as an individual. We'll talk about the drugs that are available today, and we'll talk about the future, looking at residual risk. So these are just the demographics of cardiovascular disease. It still remains the number 1 cause of death and morbidity in the United States. Horrible numbers, more than 3 million people in the US are diagnosed every year, and about 365,000 deaths. 2 in 10 people are less than 65. So that's some alarming statistics out there. And why this is important to us is that Southeast Asians and South Asians, we have a higher incidence, particularly South Asians. Who all are South Asians? People from countries like India, Pakistan, Bangladesh, Sri Lanka. Some parts of Burma would also count as like South Asia. So these people have 2 to 3 times higher rates of atherosclerotic disease as compared to their other counterparts from other ethnicities. So I'm going to open this talk with lipids, because this is still the most important and most studied risk factor in today's day and age that can be modified. Of all the lipids, we talk about LDL, which is the bad cholesterol. That has the most data, and that has been proven over and over and over again to be the biggest culprit for coronary artery disease. Other portions of cholesterol, such as HDL, which is the good cholesterol, those data are still investigational at this point and are not stellar by any means for us to recommend that everybody should be working on the HDLs. If you find that you have high HDL, great. But if somebody has low HDL, focusing entirely on low HDL and trying to raise that, I don't think that's really worth it based on the data we have today. Triglycerides are also emerging as possible risk factors. So if you were to focus on one thing, as of now, focus on LDL, which is low density lipoproteins cholesterol. So if you can take one thing away from my talk today, please remember that cholesterol is inflammatory. Your arteries do not like inflammation. The cholesterol that you consume gets inside the cell and then it gets oxidized. This is this oxidized LDL, which is the biggest culprit for coronary artery disease. Because as this cholesterol gets oxidized, the size of the cholesterol particle decreases. This is just a schematic to tell you what exactly happens inside the cell. The blue is your normal cell membrane. And the red here that I'm pointing to stands for the cholesterol particles. So this is a normal person who's eating some amount of cholesterol. And you can see that this person can still get nitric oxide, which is really good for your arteries. As the disease progresses, there's a fair amount of red deposition in the cell membrane. That is not good. And that leads to decreased production of nitric oxide. Towards the extreme right, you have this patient who has complete infiltration of the membrane with cholesterol all over. This leads to cell death. And this leads to death of cells that are lining the arterial wall. What does this cause? This causes the plaque to rupture. And what does that mean in common terms? When the plaque ruptures to a common man, it is a heart attack. So please remember what I said. Inflammation is bad. Cholesterol is inflammatory. Cholesterol causes plaque to break after it is built up over a long time. It's the inflammation that causes it to break. So this is just a schematic that tells you the same thing. This is all some big names for these things. This is a bad enzyme, caspase 1. And this is a real bad player, IL-1 beta. This is the one that causes cell death. All right? So we'll talk about this later when I show you some slides as to some drugs that work on IL-1 beta. This is another slide that tells you that there's certain good drugs that can actually take the place of cholesterol in the membrane. So you can see that these are your normal membrane lipids. This is the bad thing, that is cholesterol. And this particular medication that's called EPA, icosapent ethyl, this actually takes the place of cholesterol in the membrane and prevents deposition of further cholesterol. So in the past, people were talking about HDL, HDL, HDL. When I'm talking to my patients about the LDL being high, they'll argue back to me saying, so what? My HDL is really high. Why do you think I'm at risk? For this reason. In the past, we always focused on saying high HDL is great. But you have to understand that HDL can only work in a functional environment where there is less inflammation. So if you have tons and tons of inflammation, I don't care if your HDL is 100, you will still be at risk for plaque rupture. So our goal in the future is to decrease cardiovascular risk by decreasing inflammation, and then we can increase the functional HDL, which can actually do its job. Triglycerides, let's think with that. Triglycerides are also inflammatory particles. So these start off as high density particles and large particles, but then they break down into something that's called triglyceride remnants. And you can see the size of these triglyceride remnants is smaller than actual triglycerides. So triglycerides cannot directly get inside the cell, but these triglyceride remnants can get inside the cell. They do the same exact thing, incite inflammation, cause plaque rupture. All the bad things, insulin resistance, oxidative state, and then ultimately plaque rupture. So these are some genetic cholesterol syndromes. The first one that everybody talks about is familial hypercholesterolemia syndrome. This is a syndrome wherein somebody has really bad LDL cholesterol. So the LDL cholesterol is greater than 200 milligrams percent. Normal person should be less than 100. You're almost twice that of a normal person. And the worst thing that I said is these cholesterol particles are oxidized. See, these are small and they can easily get inside your arteries. What do these people present with? They have early heart attacks, strokes, cardiac deaths. Not that uncommon. The heterozygous form of this is seen in 1 in 250 people. And the homozygous form is really rare. That's seen in 1 in 500,000 people. You can pick up these people pretty quickly just by doing a physical exam in the office. These people have oftentimes deposition of cholesterol around their eyes. See these orange things here? Yellow, orange. These are the ones that are deposition of cholesterol. This is called xanthelasma. They also have deposition of cholesterol around the tendons at the back of their legs, the Achilles tendons. These are called xanthomas again. Other syndromes that talk about elevated triglycerides, they also increase your risk to a certain degree, but not as bad as LDL. Lipoproteins. What are these particles? These are not typically the LDL, HDL things that you talk about. These are things that have emerged over the years as inflammatory particles. As the name suggests, they contain a lipid particle, the lipo, and they contain a protein particle, that is the protein. The lipid particle is very, very similar to LDL, so it increases atherosclerosis. The protein particle the ApoA, what does that do? That prevents clot breakdown. So what's the end result? Too much plaque and too much clot. That is a setup for death if you actually get acute coronary syndrome or a heart attack. The bad part about this thing is this cannot be measured by your standard lipid panel. So if you just get your cholesterol checked, guess what? It's not going to tell you what your lipoprotein A levels are like. It's not very well studied, but this is emerging as a risk factor, especially in ethnic populations, more so in Indians and South Asians. Now I'm going to switch gears and talk about the next problem, which is obesity. This is a growing problem in the society. Latest data do suggest that 42% of the US population is now obese. So if you look at the body mass index, a normal person should be between 20 and 24. All you guys are probably rolling your eyes at me and says, who has a BMI of 20 or 24 anymore? But there are people that live like that, all right? A BMI of 20 to 24 is considered normal. Well, if you're under 20, then you're considered underweight. Once you're over 25, you're called overweight. If you cross 30, you're called obese. And when you're over 40, you're called morbidly obese. So that is the classification of obesity. No obesity talk can be complete without talking about the patterns of obesity. So this is what we call the fruit test. So you can look at a patient's obesity pattern and say if they look like an apple, which means that they're bigger in the center, or they look like a pear, wherein most of the fat deposition is around the hips. All right. So this type clearly tells you that the apple or the visceral obesity is the bad one. All right. So whenever I look at a man in my office, if it looks like he's got a big belly, he may be skinny elsewhere, but if he does have a big belly and is round in the center, or always tell them, sir, you have a higher risk of coronary artery disease. Now, if I look at a woman who looks like that, even worse, all right? Women are not supposed to have that kind of a pattern, but if a woman looks like that, she really has higher risk for coronary artery disease. So this is the one that tells you these are fit people. This is the visceral obesity. Look at this man with a big bump here in the center. And this is a woman with a typical hip, which is like the subcutaneous obesity. So the visceral obesity, it's a risk factor and it's a part of the metabolic syndrome. What exactly is the metabolic syndrome? Rampant in Indians and South Asians, all right? Serum HDL is less than 40. Triglycerides are more than 150. Blood pressure is not quite 140 or 150, but it's slightly over 130. So it's 134, 136. Lower number is over 80. That does qualify as metabolic syndrome. The waist growth is more than 35 in women, more than 40 in men. And if your fasting glucose is more than 100, if you meet more than 3 criteria, you qualify as having metabolic syndrome. Why is it important to know if you have metabolic syndrome? If you look at the survival curves of normal people versus those of diabetics, you will see that the ones in the middle are the ones that have metabolic syndrome. And you see that as early as 3 years after they develop metabolic syndrome, their curves start to look different from normal people. It won't be long before they start to go down. 5 or 10 years down the line, they can match up with diabetics, all right? So this is why it's important to know that if you have metabolic syndrome, you've got to act on it. So is dieting effective for obesity? Well, no successful regimes have shown sustained weight loss, all right? People can do these kind of diets, they can run a marathon and they can do something for 6 to 8 weeks. But no diets have clearly shown that they can long-term sustain this thing. You have to make it a way of life. You can't go on a diet for 6 weeks and kind of like think that, okay, now that I've lost this weight, I'll keep it off. It doesn't work that way. It has to be a way of life, all right? The other thing is short-term requires like both dieting and increasing physical activity. So if you're going to say, I'm just going to like restrict my eating, but I'm not going to work out at the gym, I'm not going to increase my physical activity, please know that it's not going to help you. Second thing, if women talk about using that as a way of losing fat around the hips, they have shown that short-term waist-light trials really do not affect subcutaneous obesity, which is the hip pattern. They can affect your visceral obesity some. So the ones that are talking about the belly, yes, you can lose that. Not so much around the hips. So in summary, I've said visceral obesity is the bad one, which actually has worse cardiac outcomes. This is the doctor's job to address this at every office visit with the patient, challenge the patients to demonstrate a 5 to 10% body weight loss every 6 months. Diets do work, but they're harder to maintain. I'm going to switch gears here and talk about the next very important thing, which is diet. You might probably look at my slides and go, this guy spent a lot of time talking about diet. He should probably be a nutritionist. Well, maybe that, but this is really important. Us Indians, we like to eat a lot, all right? We have these little get-togethers and stuff. It's all about food for us. So I'm going to spend a lot of time talking about food. The Western diet has become increasingly popular because of globalization and a busy lifestyle. Fast food chains have spread throughout the globe. Working couples do not seem to have the time to cook every day. Packaged food consumption has increased fivefold. I would say that number is probably an underestimate. It's way more than that in the last 20 years. So these are the different diets that people talk about. All right. On the very left side of the screen, you see a vegan diet or a vegetarian diet. And to the extreme right, you see a ketogenic diet or the Atkins diet. So the left side of the screen represents a high carb, low fat diet. As opposed to that, the ketogenic Atkins diet represents a very low carb, but a very high fat kind of diet. All right. So the vegan diets includes fruit, vegetables, legumes, grains, nuts, maybe some eggs, but vegans probably don't tolerate that in India. Vegans here call themselves vegans if they eat eggs. All right. Dairy, that is all okay in the vegan diet. They do not eat meat, poultry, fish, eggs, or dairy. All right. On the other hand, the ketogenic people, they like to eat fats, oils, meat, fish, cheese, eggs. Anybody who goes to a cardiologist probably will know that this is not good. But apparently this is being promoted heavily on the web because it causes weight loss. All right. These people do not want to consume sugar, grains, vegetables, or fruit. And everything else is in the middle. The best one, again, I repeat, is the Mediterranean diet, which is rich in fruit, vegetable, legumes, whole grains. And remember, this is whole grains. I'm not talking flour from processed grains, all whole grains. Low-fat dairy, olive oil, nuts, fish, and poultry. So what's the difference between the two? If you eat like high-carb diet, low-fat, versus low-carb, high-fat, no difference in terms of weight loss. That's why I say, even if you eat all this unhealthy stuff, if you're not eating carbohydrates, you lose weight. No difference in insulin resistance. So why not eat all these things? This is why. When you look at death and ischemic heart disease, you clearly see that those people that eat the keto diet or the people that eat the diet that's like high in red meat and stuff like that, they have a higher chance of dying as compared to those people that do not consume non-vegetarian food. So shout out to all the vegetarians out there. If you've been a vegetarian all your life, you've done the best thing for yourself. My parents are vegetarians. I grew up in a Brahmin family, but somewhere down the line, I started eating some non-vegetarian stuff. And now I try to get off of it. It's extremely difficult. All right. But these are the data about the vegetarians versus non-vegetarians. Now, just because you eat vegetarian stuff, does that mean that you're doing the right thing? My dad's a vegan, but unfortunately, he does have coronary artery disease. Why is that? Because when you actually see animal foods, they have higher risk of dying, higher risk for developing coronary artery disease. And you see people that eat plant foods, they have a lower chance. But what do you see here? Look at this curve here, which has the highest chance of dying. These are the people that ate plant foods. But the difference is that they ate the unhealthy plant foods. They were not eating fruits themselves. They were actually drinking fruit juices. Don't buy those sweetened fruit juices. They contain a lot of like artificial sweeteners and all the bad things. Sweetened beverages, grains, refined grains, not whole grains, refined grains, potatoes, fries, and sweets. Indian diet is extremely rich in all the sweet stuff that you eat around all these holidays. You've got to be very careful with that. So if you're going to be eating all that and calling yourself vegetarian, you have no risk. I mean, you're not doing yourself any favors. You'll still remain at very high risk for coronary artery disease. On the other hand, if you eat whole grains, fruit, vegetables, nuts, legumes, oils, tea, and coffee, you're doing good there. Message number 2, eat them whole. Don't squeeze them. I always say eat your fruits whole. They give you the best. They give you fiber, and they give you sugar that can be easily digested. These things here, they give you processed sugar that is horrible to digest, gives you insulin resistance, gives you diabetes. So if you're doing the paleo diet or if you're doing the high fat diet, what can you eat? You can eat these things here: fresh fruit, vegetables, nuts, seeds, chia seeds, flax seeds, pumpkin seeds, sunflower seeds. Any of those are considered very good. You can eat those. You can have some eggs. You can have some oils like olive oil. Don't eat all these things like dairy, milk all the time, potatoes, refined oils, processed foods, red meat. That is something you do not eat. Am I saying that the keto diet is bad for everybody? No. If you talk to some doctors, they will say that there is a place for keto diet in medicine. Neurological disorders, people that have Alzheimer's disease, Parkinson's disease, they do need more cholesterol. All right, migraines, pediatric epilepsy, even people that are really obese, it does help them to lose some weight. All right, so for these conditions, keto diet is useful. Now, I definitely want to go over this one statement from the AHA. They actually talk about certain patterns. Skipping breakfast. increases your chances of coronary artery disease by 27%. This statement was issued by the American Heart Association. All right. They also encourage some healthy practices that we as South Asians do. Intermittent fasting is considered extremely healthy. It's good for reducing weight, triglycerides, and insulin resistance. Do not eat large meals at a time. Those are considered detrimental. Late meals, 10 o'clock, 11 o'clock, 12 o'clock. And I should probably be the last person to talk about things because being a doctor, I don't know when I eat my dinner. Sometimes it's at that time, but that is considered a very bad habit. So these are the recommendations from the AHA. A diet emphasizing vegetables, fruit, legumes, nuts, whole grains, and fish is recommended. Replacement of saturated fat with dietary monounsaturated fat and polyunsaturated fat is helpful. That's pretty much the gist of what the AHA said. I'm going to talk about the Mediterranean diets and multiple other diets now. So if you look at the Mediterranean diet, this has the best data in terms of reduction of cardiovascular risk. So this is the pyramid of the Mediterranean diet. So they see mostly they include vegetables and fruit. They have some whole grains, beans and legumes. They have fish and seafood. Dairy and eggs are very little and very little white meat. They do not have place for red meat. All right. So they can have some eggs, and the oil that they use is the extra virgin olive oil, oftentimes abbreviated as EVOO, EVOO. All right. Combined with DASH diet, which is low sodium, people have seen excellent results from that. There's another diet that's called as the SSC's diet. This is a guy out of Cleveland Clinic who claims that he can reverse disease just by eating plant-based diet. He makes big claims. I'm not so sure if everything that he says is validated, but regardless, it's a good diet. This is the data on the Mediterranean diet, and you can see clearly that people that eat the Mediterranean diet, they actually do much better, and their risk of death, stroke, is much lower than the regular people. Interestingly, I want to draw your attention to the fact that those people that ate the Mediterranean diet and they used an extra teaspoon of extra virgin olive oil, they actually did better. So this is the first time you'll see that somebody used more oil and still did better. Now let's talk about saturated versus unsaturated fat. Saturated fats are bad, all right? Lard, palm oil, those are saturated fats. Coconut oil, also saturated fat, all right? Monounsaturated fat is extra virgin olive oil. Polyunsaturated fat is the safflower oil and the oil, the nuts that give you the oil. Those are all considered polyunsaturated. Eggs give you cholesterol, but not saturated fat. If you're a person that likes to eat cheeseburgers, I'm sorry to say, you're really hurting yourself. You're getting cholesterol and saturated fats. Stay away from that stuff. Now let's talk about trans fats versus good fats. I'm not here to say that every fat is bad. All right, the trans fats are the ones that do all the bad things on this side of the table, raising your chances of a heart attack and stroke. These fats here, the fats that you get from nuts, extra virgin olive oil, avocados, seeds, salmon, and other fish, these are the good fats. So you can eat these fats and still do okay. This is again something that shows you that if you replace your diet with carbohydrates from refined starches, added sugars, you do poorly. Trans fats, you do poorly. But if you use monounsaturated fats, polyunsaturated fats, and carbohydrates of whole grains, you do better. No Indian talk can be complete without coconut oil. This is why I specifically put up this slide. It contains 82% saturated fat. That's the bad part of the coconut oil. But it also contains some monounsaturated and polyunsaturated fat. There is some place for coconut oil in medicine. It's just that for coronary artery disease, it's not considered the best kind of thing. Again, remember message number 2. Eat them whole. Don't squeeze them. So on the right side of the slide, you talk about this particular community. I can't even say this. Puka Pukans and the Tokelauans. I think they are from a Melanesian island. They eat a lot of coconut, but it's raw coconut and actual whole coconut pieces. They do not consume coconut oil, but they cook with whole coconut. And guess what? They have the lowest risk of coronary artery disease. Again, remember what I said. Eat whole fruit, eat whole coconut. Do not get the oil out of coconut. Do not get the juices out of fruit and try to get the sweetened fruit juice. Carbohydrates. Am I here to say all carbohydrates are bad? No. Remember Goldilocks? She was the girl that walked around the bears' houses and she found one that was too big for her. She found one that was too small for her, and there's one in the middle that was just right for her. This is the exact story with carbohydrates. If you eat less than 40% carbohydrates, you don't do well. You can have increased incidence of AFib. You eat more than 70%, you don't do well, and you have coronary artery disease and diabetes. Right in the middle, you do perfectly fine with that. Fiber, this is the most important thing. This is why we always say eat your greens. 25 to 29 grams of fiber a day does great for you. When you eat fiber, you actually increase the concentration of butyrate because you grow a certain kind of bacteria in your gut from eating fiber. And butyrate is anti-inflammatory and good for you. So this is a slide that just tells you the fiber content and the fructose content. So if you look at certain fruit, they have very little fiber, grapes, for example, but they just contain fructose. So try to avoid eating too many grapes. These fruit here at the bottom, pumpkins, watermelons, pineapples, they have a lot more fiber. So try that. Anybody that's allowing raspberries, you're doing the right thing for yourself. It decreases your chances of developing diabetes. So 2 cups of raspberries really does very good for you. Why is meat so bad? Cooking meat at high temperatures, especially the grilling, remember the grilling alters the meat and it increases your chances of developing hypertension, 15% increased risk of hypertension. Also, remember, mammals are very similar to what we are. So if you're going to be eating cow, pig, they're also mammals, all right? So they have certain products in their body. Those are somewhat related to you. A plant is really very distant from you as far as evolution is concerned. So when you put animal fat in your body, animal products in your body, you can slowly develop a hypersensitivity and you can develop an anaphylaxis to that. Anaphylaxis leads to inflammation. Inflammation leads to plaque rupture. So that is why red meat is bad. Another thing with red meat is a compound that's called trimethylamine nitric oxide, TMAO, TMAO. Anytime you eat red meat, egg, fish, and poultry, gut bacteria feast on choline that is present in these compounds, and then they produce trimethylamine. This goes to your liver, and the liver converts this trimethylamine into trimethylamine oxidized. All right? This itself raises your chances of having a heart attack and stroke by more than 2 times that of a normal person. This is why the Western diet does not lead to good cardiac outcomes. So this slide just tells you how you increase your risk. Red meat, processed meat increases your chances for mortality from cancer and cardiovascular death. If you want to eat processed breads from processed grains along with red meat, you're really hurting yourself. What about eggs? Eggs are considered very good for most people, except I did mention that the yolk of the egg, the yellow part, does contain some cholesterol. All right? Moderate egg consumption, 1 to 2 eggs per day, did not translate into bad outcomes in most studies. All right? What about fish? Whole fish is not bad. Remember my second rule, eat it whole. Don't squeeze it. All right? As long as you're eating the whole fish, as opposed to the dried fish, which is squeezed, you're doing well. All right? Whole fish leads to a decrease in heart attacks and also decreases, like 100 grams of fish, decreases the chance of like developing acute heart attacks. What about chicken? Most Indian diets, Asian diets are very rich with chicken for those people that eat non-vegetarian food. The data are neutral, but when you look at who funded this talk, who funded that study, it was the poultry industry. So you've got to take that with a grain of salt. So mostly they say the overall data is neutral for cardiovascular data outcomes and also cancer outcomes. But when you dissect it and look at certain particular conditions, there's a 15% increase in hypertension, high blood pressure, and a 27% increase in pancreatic cancer. All right, that's not a small number. So the best is to be vegetarian. This is only one trial from India that has been published. That is why I put up this article. There is a Mount Abu open heart trial. What do these people do? They did a heart cath on people before they started them on a healthy lifestyle. And the good thing about this paper was because they also had yoga. This is what attracted the attention of the Western people. And this is how this paper made it to PubMed. All right. 91% of people that got into this regime demonstrated a decrease in their coronary stenosis. 6 months, they were followed, for 2 years, every 6 months. And at the end of 2 years, they had a heart cath. So in 2 years, 91% of them actually demonstrated that the coronary stenosis had decreased. The critique to this article was, yes, they demonstrated decreased coronary stenosis, but it did not look at death, cardiovascular death, or strokes. So good trial, if they could just have done this a little bit more to see how many people lived at the end of 2 years, how many people died, that would have made this an excellent paper. But this is still a very good paper out of India. Don't use artificial sweeteners. They have increased the risk of stroke and dementia. So please, if you're being told to sort of like just cut down on sugar, get used to doing without sugar, eat fruit and get away with it. Do not use these things. These are really bad. Legumes, these are very rich in the South Asian diet. Chickpeas, all these other things, beans is extremely good. Use them a lot. Whole grains, I can't say anything bad about that. Millets, barley, corn, all these things. Quinoa, of course, all those things are very good. They help your weight, waist circumference, blood pressure, triglycerides, everything. So this is just a summary slide. Green light to whole grains, fruit, vegetables, legumes, nuts, seeds, and fish. Red light to salt, red meats, processed meats, artificial sweeteners, and refined grains. This is considered a healthy plate. So all of these people want to ask me, doctor, what should I eat? You tell me don't eat this, don't eat that. That's why I put up a picture of a healthy plate. 30 to 40% of your food has to be greens. 25% has to be protein. 20 to 25% can be starchy carbohydrates. Now, what is that to us, to South Asians? This is dal. This can be chawal, which is rice. This can be, all right? So this is important. And 20% has to be grains and legumes. So this is an example of a healthy Indian plate from the north of India where they use more roti. Yet you see a lot of greens. You see some fiber here. There's protein from dal. And then there's other things that we're talking about. The remaining components are, they don't have any legumes here as much, but this other person seems to be eating some legumes here. This is moong, all right? And this is the beetroots and everything. So this is an example, healthy example of greens, legumes, everything, all right? And the main thing that I put this slide up is to show the proportion of rice. This should be the proportion of rice that we should be eating. Unfortunately, most of us do not follow this. When I look at somebody's plate who's from India that is flooded with rice and more and more and more rotis. So with age, try to cut down on the rice and eat more of these things. All right, vitamins, please don't take them. They don't do any good. So if you're taking vitamin B6, vitamin B12, just for if you don't have any deficiency, don't take it. What about fish oil? This is a $1 million scam in the US, all right? Do you know how fish oil is manufactured? Fish are caught, cooked, and pressed, separated into two streams. What did I say? Eat the fish whole. The minute you squeeze them and press them, they don't do very well, all right? Water is removed. And then it leaves a liquid phase and a solid phase. The solid phase is used to feed fish, aquaculture, animal feed. The liquid phase is used to prepare fish oil. They have 18% EPA and DHA, 12% DHA, which is the good stuff, but they have 70% of all this bad stuff. Next thing, they are not controlled by the FDA. So they're classified as a food item. So nobody's required to check the purity and the content in these things. My advice, please don't take it. All right? Get a prescription from the doctor and take a prescription strength fish oil if you're interested. Take a prescription strength plant oil if you're interested. Don't waste your time getting fish oils from the market that are over the counter. No Indian talk can be complete without chai. Tea. Tea is good for everything. Cardiovascular disease, stroke, cerebral infarction, intracerebral hemorrhage, and coronary artery disease. So please continue to drinking chai. I feel extremely proud of myself. I don't care what time of the day it is, I can always have chai. So I love my chai. Okay. This is the exact opposite of chai, which is all these other drinks. They contain a fair amount of sugars and other ingredients that are not controlled. These are bad. They contain ginkgo biloba, ginseng. They can interact with multiple other medications. If you're taking blood pressure medications, if you're taking blood thinners, please do not take these things. Okay, that's all about diet. I know I spent a lot of time talking diet, but that's important. Next one is exercise. So this is the spectrum of exercise. Well, there's no lower limit, all right? Look at this guy sitting on the couch. This is like a couch potato. Don't be this person. Even if you walk around the house, that's considered okay. This is what we consider the people that actually go to the gym. They're doing a good job, all right? And when you actually go too much beyond doing triathlons, marathons, and stuff like that, you oftentimes see these people drop dead during marathons and things like that. You have to know that at a certain point, the benefit peaks. Beyond that, it's just a hobby. You're not getting any more cardiovascular benefit. So what does the ACC-AHA recommend? 150 minutes of moderate intensity every week. So if you do the math, 5 days a week, 150 minutes, half hour every day, 30 times 5 days, 30 minutes every day for 5 days. That's what you should be doing. Moderate intensity, walking, running, maybe some jogging, that should be good. 75 minutes of vigorous intensity. If you're like a marathoner, or if you want to run the treadmill at 6 miles an hour or higher, that's vigorous activity. Combination of cardio and weights is preferred. For those people that want to go to the gym, avoid using supplements or powders containing caffeine and testosterone. They don't do any good, increase your chances of a heart attack. Achieving healthy weight, for that, you have to combine that with the caloric reduction. So you have to cut down on the calories that you get from the food, go about healthy food, take more fiber. When you eat more fiber, you increase your stool volume. You actually excrete much more stool. And the more stool you make, it excretes more energy. And that way, I think your caloric intake in the body goes down pretty well. Comprehensive lifestyle for more than 6 months and increasing physical activity to more than 150 minutes of brisk activity a week. This actually does pretty well. Now I'm going to talk about blood pressure, smoking, and aspirin really quick. So blood pressure, the goal blood pressure now is less than 130/80. for people that actually have coronary artery disease, it's less than 130/80. If you have certain risk factors, again, it's less than 130/80. For all others, I think it's 140/90. I'm not going to talk about blood pressure medications. That's a separate topic for another day. If you're a person that smokes, I just want you to know that today there are multiple options that are available. Most of the time, cardiologists do not prescribe this. It's a primary care provider that prescribes it. There's a patch, a gum, a lozenge, a nasal spray, or an inhaler. All these options can help you to quit. Bupropion, varenicline, otherwise called as Chantix. You see that I don't have e-cigarettes on this thing, all right? E-cigarettes are considered worse than regular cigarettes. So please do not use cigars. Please do not use e-cigarettes. Those things are really bad. Aspirin, you have to look at the bleeding risk versus the benefit. Considering everything, I would say in today's day and age, do not take aspirin unless your doctor says you need it, all right? All these trials have shown that people that were taking aspirin, they had some benefit, but the benefit was outweighed by the bleeding risk that they had. Especially if you're over 50 and if you have like some problems with your colon, you will bleed. So don't take aspirin if you don't have to. Now, if you have coronary artery disease, if you've had a heart attack, if you have a stent, you have no choice but to take aspirin. Now, I've spoken a lot about diet, exercise, obesity, everything. How do you put this all and combine it into a patient? This is what you do. People used to use a risk score that was called as a Framingham score. But this was notoriously insensitive to different ethnicities and to people that had multiple other problems. So in 2013, the ACC/AHA came out with a risk score that's called as a pooled cohort equation. So this equation looks like this. It looks at your gender, it looks at your total cholesterol, looks at your bad cholesterol, looks at your blood pressure, looks at your your blood pressure when you're taking the medication, if you're diabetic, and if you're a smoker. Based on that, it calculates your risk. If your risk is more than 7.5%, you should go on cholesterol therapy. Statins is what we recommend. 40 to 75 years of age, provided you do not have established coronary artery disease and you do not have the disease that we talked about in the very beginning, familial hypercholesterolemia. Some people might go, you know what, in my family, I've had people that are 30 years old that died from this. So your risk doesn't even include us. It only starts at 40 to 75. So they've now said that if you're between 20 to 39 years of age, you should not just look at the risk for 10 years, but you should also calculate what we call a lifetime risk. And if that is an elevated number, you should still be treated like you should be going for statin therapy. So this is where we become important. All this time, there was no special recognition for our community, South Asian community. For the first time in 2017, when they changed the guidelines, they mentioned this, that South Asian communities have a higher risk as compared to all other communities. So even if your risk is less than 7.5%, but if you're Indian, if you're Pakistani, if you're Bangladeshi, or if you're Sri Lankan, you will still qualify for statin therapy because your genes actually predispose you for a higher risk. Anybody that has a positive family history also qualifies for that. Metabolic syndrome that we talked about, if you have a chronic inflammatory condition like rheumatoid arthritis, certain biomarkers like lipoprotein A, the last thing, coronary calcium. Some of you might have seen me as your cardiologist and I've recommended this, that we check calcium inside your coronary arteries. It's a quick CAT scan. And all we look for is you have calcium in your arteries or not. It does not tell you how narrow your arteries are. It doesn't tell you if a 90% blockage, 70%, 80%, but it tells you that if you have coronary calcium, you should be considering statin, all right? You should only use coronary calcium if your risk is between 5 to 20%. If your risk is very low, don't use coronary calcium. It doesn't work very well. And if you have a very high risk, if your risk is over 20%, you should go directly on a statin. And this is pretty much what I was saying, that even if your risk is low, all right, even if the pooled cohort equation says that your risk is like 5%, but if you have a calcium score of greater than 100, it automatically pushes you from 5% to more like 10 to 15%, all right? So keep that in mind. Now, is Dr. Hegde here to tell you that everybody needs a statin? No. I will tell you that when you see these guidelines, everybody qualifies for a statin. Do they all need to be on statins? A lot of my patients will come and argue with me. Do I need to be on a statin? That's when I'll say, technically, yes. But when you look at all the patients and they check them for coronary calcium, guess what? About half of these patients, 41%, 57%, sometimes 79%, all of these people, about these people did not have coronary calcium. So if you do not have coronary calcium, and just because your risk is like 8% or 9%, sometimes you can say, I don't want to take a statin, that's okay. But you have to remember that calcium score can be falsely negative in HIV positive patients. So if somebody is HIV positive, they should automatically go on a statin because calcium score is insensitive in those people. Same thing with people that are under 40 years of age. You've just had 40 years of your life. You've not had enough time to build up calcium. So if you're under 40, try not to use that as your only argument against a statin, all right? So if you're under 40, I would probably say, even if your calcium score is negative, if you have a strong family history, I'll still sometimes say you need to go on a statin. Now we're going to talk about medication. My favorite, statins. I know there's a lot of people that do not like me for saying this. There's a lot of bad press about statins, and we'll talk about that. But end of the day, these are the medicines that have actually changed cardiology. This makes me realize how old I am and how long I've been in medicine. I was probably these drugs came out when I was in medical school 20 years back or 24 years back. So that's when these drugs were new, all right? And if somebody asked us these medications on our board, we were like, oh my God, that examiner asked me really difficult questions. But these medications are extremely important. All these trials have shown that they save lives and they decrease your chances of a heart attack. Now, what are the arguments against statins? Some patients cannot tolerate them because they actually have muscle aches and pains. Most of my patients, if they take them with a supplement that's called coenzyme Q10, that's how it actually lowers your chances of developing any problems. Same thing, there's a small increase in the chance of diabetes, but then this only happens in people that have a family history of diabetes or metabolic syndrome. The benefits of statins far outweigh the risks. I still say they should go on statins. For people that really cannot take it, here are some drugs, Zeria. There's a new drug, bempedoic acid, called Nexletol or Nexlizet. These drugs decrease your cholesterol, but we do not have data on death or cardiovascular disease. PCSK9 inhibitors, these are injectables. Even they decrease your LDL cholesterol. And there's some data that they may also increase your chances of dying. Now, the last one is a really important drug. This is being studied. Look how frequently this is injected. Twice a year. Wouldn't this be nice, to take a medicine every day? This is only injected every 6 months. And this actually can decrease your LDL. And if the studies come back positive for decreasing death, this will be the way to go in the future. You just take a cholesterol medication twice a year. That's it. Other drugs like fibrates, niacin, no robust data, so I'm not even going to go there. This is the case scenario of a 75-year-old Indian male, strong family history of premature coronary artery disease. Grandfather died at 42 from a cardiac arrest. Father at 45 from cardiac arrest. Younger brother at 60 from cardiac arrest. All of them died in the setting of a massive myocardial infarction. He also has type 2 diabetes and is on oral meds, has been a lifetime non-smoker and is a vegan. He underwent a 5-vessel CABG at the age of 60, and he had a stroke at the age of 68. Guess what? His LDL was only 10 milligrams percent. All right? Under 70 is considered like the best cholesterol you can talk about, and he was only 10 milligrams percent. And he still had a stroke. Non-obese, very physically active for his age, asked you for advice about cardiac risk. What do you do? As a matter of fact, this 75-year male is my dad. This is my dad's story. He actually did everything right. He's a vegan, never smoked, did nothing wrong, but developed diabetes, and then he had a bypass, and then he had a stroke. So this is what takes us to the concept of residual risk. So just because you treat your cholesterol, LDL, and all that stuff doesn't mean that everybody's going to respond. There are factors beyond cholesterol. Inflammation. I've been saying this throughout my talk. Inflammation is bad. So if you have inflammation, that can cause something even if your LDL cholesterol is low. If you have a higher tendency to make clots, thrombosis, that can lead to strokes. That can lead to heart attacks. If your triglycerides are up, that can do the same thing. And if you have elevated lipoprotein A, that can still do the same thing. So this is a trial that looked at reducing inflammation. They saw very good outcomes with this drug that was called canakinumab. Another trial that looked at reducing thrombotic risk by using a drug called Xarelto. Even that had very favorable outcomes, that people that took that medicine had a higher chances of survival. Then this trial looked at people not looking at LDL, but they looked at triglycerides, EPA, the drug that I talked about in my beginning. I think that also raised their survival. And lipoprotein A, this is the one that I talked about. It's bad in the Indian population. There are multiple trials that are ongoing for this thing because we do not have a good therapy for this. Niacin does decrease this by 23%, but I do not recommend niacin. Aspirin's good. Statins can be taken along with this, but statins sometimes raise lipoprotein A. PCSK9 inhibitors decrease this. Apheresis is similar to hemodialysis, where they actually put you on something, they take your blood, remove the lipoprotein A, and get your blood back to you. And this last medication, that's an antisense oligonucleotide treatment, is really making some waves right now. If this thing comes through, a lot of people will be treated for lipoprotein A. So for all of those Indians who have seen me as patients that have said, doctor, my lipoprotein A levels are up, but what can I do about it? I keep telling them, hang in there, something's coming. So in the next few years, I think this therapy will be out. So this is pretty much towards the end. I just talk about if you can't take statins, then you have certain other things that you can take, ezetimibe, PCSK9 inhibitors, and all these newer drugs that are there. Special populations, I just want to talk about what I talked about today is just here, critical coronary stenosis. Other things like inflammation, platelets and coagulation, vasospasm, microvascular dysfunction. We don't think we can even touch about these things. This is why coronary artery disease is so complex. We only handle this today, but in the future, I'm hoping that this becomes more holistic. This is a condition that's called spontaneous coronary artery dissection. This happened to a young woman, 42 years old, who was exercising, does not smoke, normal cholesterol. What do you see? Her artery tore apart. You can see this little flap inside the artery. And now you see that rather than having one cavity, she has two cavities. This is a smaller cavity, which is a real cavity. And this is the second cavity, which is full of clot. If you do the vascular ultrasound, you can see the same thing. This is the real cavity, and this is actually this false cavity. The real cavity is really small here, and the false cavity contains all the clot. What do you tell her? What did she do wrong? Nothing. This is just unfortunate. You treat this conservatively. Does not happen very commonly, but this happens to young women that have a condition called fibromuscular dysplasia. The other thing that I want to touch upon is called microvascular dysfunction, because in today's day and age, we only talk about these big arteries. What about the microcirculation? What do we do about these little things here? You can open all these arteries up with stents, bypasses, whatever. But if the microcirculation is blocked, guess what? The heart will still not get blood. So this is why treating microvascular dysfunction is also becoming more popular. With that, I'm going to stop here. I'll stop sharing my screen. I just want to thank the organizers of Red Saree for inviting me to do this talk. And thank you for listening to me. Thank you.
Thank you, Dr. Hegde, for that wonderful, wonderful talk. So we have so many questions. So,
oh, wow. Okay. I'll take them.
So many of them. So I'll go, as much as I can.
Yeah, sure.
So one of the popular question I see was like everybody's asking, can you share these slides with them?
Well, I have no problems. I think you guys took the agreement from me that this is going to be on YouTube, right? So you guys can just take it off of that.
Okay. So yeah, so that answers the question. So Red Saree is going to post these videos on YouTube, on Red Saree channel, so you can watch it again and again if you have any.
Because I covered a lot. I covered like so much in these 30 minutes. I mean, like, yeah, I understand if people felt like I was rushing, you can go back and take a look at the slides, but I just want to cover everything that is important.
Okay, thank you, Dr. Hegde. So I'll start off with the first question. So this is from Dr. Samir Khalgate. So how to measure BMI? General question for the uninitiated.
Oh. So body mass index measures your height and your weight. That's pretty much how you calculate that. And you have an online calculator that actually gives you body mass index. So this is the common way of measuring BMI. Now there are some flaws to it, all right? Because your BMI can be up just because your weight is up. So if you look at some athletes that exercise a lot, guess what? They have a lot of muscle, all right? That muscle will translate into elevated weight. So when you actually get your weight may be up because you're actually more muscular. This is why this is the biggest critique for BMI, that the BMI is not a perfect measure. So people that are very muscular may always have like a higher BMI, does not mean that they're unhealthy. So that's the biggest critique to BMI. I don't see any special way to measure BMI. The BMI is derived from your height and from your weight. You go online and then you have that thing. You calculate your body surface area. So your weight divided by your body surface area gives you a body mass index. That's how you calculate the BMI.
Okay, thank you. So the next question is from Mr. Suresh Pannala. Wonders, how do organic poultry or commercial poultry affect people over time? Similarly, what are your thoughts on wild-caught fish versus farm-raised fish?
Okay. So now these questions, I do not think can be answered very well at this point, because I will say that people that have actually sponsored these studies, I put that disclaimer in there, all these studies are sponsored by these companies. So unfortunately, they do tend to say that the organic chicken does better. The farm-raised fish do better, all right? But in real life, when you actually look at those communities that I talked about, these are like in the middle of nowhere, some islands where they see like a very, very low incidence of coronary artery disease. These people eat fish. All right. They don't care for these farm-raised fish. They don't care for the organic chicken. They just eat it. All right. So that's why I say that take that with a grain of salt. If a particular company is actually sponsoring the trial, they're always going to make their products look good. So take that with a grain of salt. In reality, I cannot opine whether one is versus and better than the other. But if you look at the data that are out there, they do say that organic chicken and farm-raised fish do better.
Okay. Thank you. The next question is from Mr. Ram Medapati. He's asking, is intermittent dieting well for weight loss?
So yes, intermittent dieting and intermittent fasting do pretty well for weight loss, but what you eat on your fasting day makes a huge difference, all right? So some people say that on my fast day, I can fast, but I eat bread. Well, you just destroy the whole purpose of a fast. So if you're going to replace your regular meals with bread, which is just processed carbohydrates, you did the wrong thing for yourself. Some other people will say that, yeah, you know what, I can't eat much else. I ate sabudana, which is fine, khichdi from that is fine. But then there's others that say that I want to eat ice cream all day long when I'm fasting. So if you're eating those things, you're hurting yourself. So if you're fasting yourself and you make it a true fast where you only eat some fiber, which is like more like a little bit of vegetable, if you have some little bit of fruit, maybe a little bit of sabudana for starch, I think that's considered okay.
Okay. So the next question is from Mr. Srini. What is the threshold level for dairy altogether per day? Say like milk or yogurt or both together.
So 1 glass of milk today is considered like good for everybody. All right. So if you're an adult, I'm not talking about kids. Kids have different requirements. Today's talk is all about adults. So for a grown adult who's more than 18 years of age, 1 glass of milk is considered okay. Now, if you want to use the fat-free milk versus this and that, does not really make that big of a difference. Milk is milk, yes. But I mean, those people for weight loss reasons, I think the skimmed milk or the fat-free milk is better.
So next one is very interesting from Mr. Samir. So how about exercise regularly with good diet? So because
that is exactly what my slide showed. I said that, you know, it has to be together. You can't do one or the other. All right. If you just starve yourself, it's not going to work. All right. You have to start. Just think about this. You know, the common analogy that I tell you is like, you know, if you're filling up a tank, if you filled up the tank with water and all of a sudden you turn the water off, and if you don't open the tank to remove the water that is there, the tank will always remain full. You see my point? You have to do both. You have to stop filling the tank and you have to start emptying the tank. That's how your body's going to lose the calories. So if you just do one, it's not going to work.
So the next part of the question is, you know, for meat lovers, how much meat is okay as it would be?
So like I said, the healthy plate does say that 25% of your meat can be white meat, which is like chicken, poultry, like turkey. That's considered okay. Fish is also considered okay. That certain fish like salmon are considered good. Certain other fish like tilapia, those are also considered good. Mahi is okay. I think those kind of fish are considered okay. I think salmon, Atlantic salmon is considered the best fish. So if you want to eat meat, those are the things. I'm not saying I don't eat red meat, but for those people that like to eat red meat, once or twice a month is okay. But I just showed you slides that when you constantly eat red meat, your gut flora gets altered. And then you start getting TMAO, which is very harmful. So if you want to do meat, do it very intermittently, once, maybe twice a month. No more than that.
So the next question is from Mr. Srikanth. He is asking, is there any special suggestions for pre-diabetics?
Metabolic syndrome is pre-diabetes. So whatever I said for metabolic syndrome, exercising, dieting, watching the diet, do not eat stuff that has a high glycemic index. Try to cut down on rice. Use more of vegetables. Like I said, if you excrete enough stools, you will kind of have caloric loss in the stools and you'll have less calories in your body. All right. So whole grains, green vegetables go a long way for pre-diabetics. So they can prevent the onset of diabetes by doing both of this, what I just said. Whole grains, vegetables, and try to get your sugars mostly from fruit as opposed to getting like cakes, all these cheesecakes and all these other things that most people in America do eat. And I'm guilty of that too, I have a sweet tooth. But yeah, for those people that are borderline diabetics, that's the way to go. And combine that with increasing physical activity.
So the next question is from Annie Thomas. So you mentioned that gut bacteria feast on choline due to increased TAMO found in red meat. Please explain the gut-related symptoms.
It's not about the gut-related symptoms as such. What happens is when people constantly eat more red meat, your body always adapts to the environment that it's being thrown into, all right? So if you're constantly doing something, your body gets used to it. So that's what happens. So over time, your body was not meant to be eating red meat, all right? So if you look at a person, when they start, people that have lived not in the Western world, but have always lived the eastern side of the world, and have never eaten most red meat, if you look at their gut flora, they have a certain kind of gut flora, which produce more butyrate, which is anti-inflammatory. Over time, if you eat red meat, this is what happens, that their gut flora changes to the kind of gut flora that do not work on greens very much, but the gut flora get altered to work on meat. And that's what happens. Sometimes, and I'm only saying this, sometimes these people might complain of bloating, gas formation, that's more common in the Western world, and constipation. As opposed to that, People that have more vegetable, they do not suffer that much with constipation, but then it's more the diarrhea kind of thing. So that's kind of the difference between the vegetarian versus the non-vegetarian gut flora.
So next question is from Samir again. So do probiotics help?
Yes, exactly. That was my answer. So for those people that live in the Western world and that they've completely modified their gut, if you see a lot of Westerners, I never thought about even taking probiotics when I was in India. I didn't even know what a probiotic was because I ate a healthy diet with like fresh fruit, vegetable, legumes that were cooked in my house every day. But when I came here, and especially when I was in residency and fellowship, I would kind of cook something on the weekends where like I made some chicken and this and that, and that's all I would eat all week. So this is why probiotics do help. When you take probiotics, the kind of strains that they have inside those probiotics are very similar to the probiotics you would find in a vegetarian's gut. Those are the ones that actually produce the healthy substances in your gut and they reduce formation of TMAO.
So the next question is from Dr. Venkatesh Sundarajan. So he's asking how to make these foods, the healthy foods, as a part of your regular diet in the busy lifestyles. Do we have to, it's a great idea to simply label foods, good or bad?
No, yeah, the labeled foods, like I said, I repeatedly said this to the talk, labeled foods don't really do very well. Just get some green leafy vegetables off the shelf. Anything like spinach, broccoli, collard greens, have a serving of that. Try to include some salads. That's one thing that we Indians don't do very much. Salad was always like a side dish. That is one thing that I've liked here when I go out to dinners, when I'm doing a talk or something. A lot of times I can order a salad, and that's like a lot of roughage that you get from that. So please go more in the direction of doing that. Eating more of those greens actually made a huge difference. I showed some slides that actually showed a happy Indian thali, which is where you can cook more greens with green beans and all the other greens basically that we use in the Indian cooking. You can have that. So just make sure that 25 to 40% of the food is from greens, 25% is from legumes, the other 25% is protein, and then remaining last 25% to 20% is like starch. That's the best healthy way to go.
I mean, he was wondering whether, you can label the food, good fruit.
Oh, I see. So there's a slide.
Something like that.
Oh, I see. So there's a slide that I put up. Remember the one that I said the green signal, eat more of these? That should be considered the good food. And then there's a slide that said this is a red signal, don't eat these. That's kind of labeling good versus bad. Try to avoid those bad foods. Try to include more of these good foods.
So the next question is, why are e-cigarettes deemed to be worse than normal cigarettes?
The chemicals that they actually use within e-cigarettes, and unbeknownst to us, when we first started opening this industry up for e-cigarettes, we thought that this was not going to be worse. We did not have clinical studies on that. But the more they started following these people that were doing e-cigarettes, they actually found that the incidence of coronary artery disease was higher. It was even worse than regular smokers. So the chemicals that are produced by e-cigarette, because people, they call it vaping, all right? So you're still doing the same thing. You're burning things, and the things that you release, those actually are cancerous, and those things are atherogenic. So that's what they have found, that just tobacco by itself is not bad. When you put 5 chemicals along with some tobacco, that makes it worse. All right, so that's the bad part of the e-cigarettes.
Thank you. By the way, that question was from Ms. Sneka Ralsekaran.
Okay.
Next question is from Dr. Venkatesh Sundarajan again. Is there any data available on nuts in preventing heart disease?
Yeah, nuts are very good. I don't know if I emphasize this enough in my talk. Nuts are very good. So people ask me, is there one nut that's better than the other? There's no magic nut. A mixed bag of nuts that considers has a combination of peanuts. I love to feast on almonds. I eat almonds all the time. So I have like a little packet of almonds on my desk. That's what I eat pretty much all day when I'm at work. Yeah, but almonds, peanuts, cashews, any nut that you can think about, walnuts, those are considered all very good. They do increase your cholesterol a little bit, but it's not so much about LDL. I think it's like more, some of the other components of cholesterol, but these are considered healthy fats.
Okay, there's an interesting question here from Ms. Malini Nagarajan. How do you tell if you have inflammation? Are there any tests that can be ordered by a doctor?
Yes. So I did say something about biomarkers. So one of the biomarkers that I do order for patients that come in to see me, especially if they do not have a documented history of coronary artery disease, I check something that's called high sensitivity C-reactive protein, HSCRP. So if your HSCRP is elevated, that's when you say that this person has inflammation. So that person needs to be treated like they have impending coronary artery disease.
So the question is a very common question everybody has. This is from Mr. Padmanabha and Ms. Sita. So is cooking with vegetable oil is good, or which oil is better? I know you touched upon olive oil, but
Through my talk, I said it's the extra virgin olive oil that is considered the best in terms of best data. So extra virgin olive oil or safflower oil, sunflower oil, those are considered good. In the end, just remember this, if you heat any oil, it's going to turn into fat. All right. So I can't sit here and say that, okay, this oil is better than the other. So I would just say that in the end, you need some oil, use the one that has got the best cardiac data. So go with the extra virgin olive oil. You can use some sunflower or safflower oil, but pretty much any oil is not good for you. So try to minimize that.
So the next question is from Ms. Satvika Thodeti. She is asking, what is the mechanism behind how a low-carb diet can lead to AFib?
And that is that we really do not know. We do not fully understand as to what exactly that is. You have to understand that the normal heart does not use carbohydrates. All right? Normal heart does not use carbohydrates, only uses free fatty acids for its metabolism. It's the diseased heart who have like coronary artery disease or any kind of like heart disease. These are the ones that actually depend on carbohydrates. So I think these people that have AFib already have sick hearts. And when you deplete carbohydrates, I think those hearts don't get what they need for their metabolism. And I think that might be a potential thing, but that is just me, Dr. Hegde, speaking that. Don't quote that. We do not understand that very well.
Thank you. So the next question is from Mr. Milton Pai. So for anemia, doctors recommend red meat. So what is the alternative for vegetarians?
For vegetarians, I think you can have a lot of options. I think green leafy vegetables give you a lot of that. Palak, spinach, is a very, very good source of iron. All right. I think I would say like that. And then even good that we use in Indian cooking, jaggery is supposed to be very good. Chana, I think, is also considered okay. So those are some natural sources of iron for people that do not want to go on the meat side. You can eat some meat, red meat, like I said, like once or twice a month, but don't make that a staple part of your thing.
So the next question is from Mr. Jay Rajendran. Is there any evidence that physical activity and heart-healthy diet reduces inflammation?
Yes. So heart-healthy diet, along with increasing physical activity, does reduce inflammation. We have seen that metabolic syndrome goes down with that. So metabolic syndrome goes a long way in terms of reducing your risks. So if you have metabolic syndrome, then I think you just have to take care of that with a good diet. So I would probably say that goes a long way. When the metabolic thing goes down, your inflammation goes down.
So the next question is very interesting from Dr. Sarayappan. We eat fried peanuts. Do you think it's good?
Okay, so peanuts are good. If you fry them, I don't think it's that good. No, honestly, that's like the answer. I showed some data on coconut oil and depends on what oil you're using for frying and things like that. Once you fry these things, the data goes down. All right. This country, people say, okay, greens are good, so I'm going to eat fried zucchini. That's the same thing. I mean, if you're frying like a vegetable, you're done. All right. All that stuff probably should be altered. So yeah, try to not do that. I've seen a couple of comments here from people that are saying olive oil should not be heated to high temperatures.
Yeah, I'm getting there.
Yeah. Okay.
Next question. So I think Ms. Lata Samu and Sita B, they were wondering, extra virgin oil should not be cooked on high heat. So it's not for cooking.
Yeah. So basically, if you remember my talk, I said like grilling stuff is not good. All right. The temperatures that you subject something to when you're deep frying it, or subjects that you actually subject them to by frying them in an oven, like when you use an oven for something like tandoori kind of stuff, that is not considered good. So if you're using extra virgin olive oil with that, it doesn't help that either. All right. That makes things worse. So the thing is, like, if you want to cook that same thing in a boiled manner by doing more of a chicken curry as opposed to doing more like the grilled kind of thing, you probably don't get to those kind of temperatures that you do with extreme high heat in the oven or on the grill. So people have looked at data on people that actually grill more stuff, like grilled meat versus in the oven versus like cooking that on a gas on high flame. If you just boil that thing, they do say that they don't quite have the same effect as they do when you're grilling them or they are baking them in an oven. So keep that in mind. Just kind of good for people to know.
So following up on oil question, there's one more question from Mr. Padmanabha. Is peanut oil good for cooking?
Again, peanut oil is somewhat in the intermediate category. It's not in the extremely high risk category, and it's not in the very bad category either. So like palm oil, lard, those are the highest risk. This is more like in the yellow zone. It's not quite in the green zone yet. So peanut oil is somewhat intermediate between high fat lard thing and the good oil like olive oil.
There is one more interesting question on gut microbiota. Can altered from Ms. Annie Thomas, can altered gut microbiota be completely cured?
Now, this is something that we'll see over time, all right? I don't think we have followed these people long enough to know what happens over 20, 30 years, all right? So you have to take probiotics for a real long time. You can't take it for 2 years and say, okay, now I'm done. So if you take it for like 10, 12 years continuously and then look at these people, you might be able to see something. Now, immediately, yes, people start to notice some difference, but it's more symptomatic difference, meaning like they start to decrease their constipation and they start to feel better. The bloating goes down. All that is better. Gas is lower as compared to a normal person. But then that does not completely take away the problem of like completely replacing and getting back what your natural gut was.
So there's one more interesting question from Mr. Kishore K. So maida and wheat seems to cause irritable bowel syndrome. So what's your suggestion to improve IBS?
That is not pertinent to cardiac stuff, but I would just say maida is again considered refined, all right? So they basically say if you have those kind of clinical conditions, you should be trying more of these other kind of like wheats that are considered non-inflammatory, basically. Whole jawar, whole ragi, those kind of things, you can try that. But again, please run this by a GI doctor. I'm not a GI doctor, and I don't want to tell you wrong information saying, okay, use this or use that. Run this by your GI doctor, but technically from the heart standpoint, anything that's not processed is less inflammatory. So use those kind of wheats as opposed to using maida.
I think we have two more questions. So one more question from Dr. Venkat Keshavani. So what are your thoughts on artificial and other sweeteners?
Okay, I did have a slide on that. Artificial sweeteners are actually worse than other real thing, okay? So if your doctor tells you that you have diabetes or your sugars are high, my best advice to you is get your sugars to fruit. Please do not use the artificial sweeteners, all right? You can use a little honey instead of that, maybe like a drop of honey or 2 drops of honey or something like that in your tea or coffee or something like that. I think that would be more advisable than actually using artificial sweeteners. There's an increase in dementia, increase in cardiovascular disease and strokes. So don't use artificial sweeteners. That's my advice.
So the next question is from Mr. Vishwa Rajagopalan. Does air fryer use have any negative effects?
Air fryer. Again, air fryer is very much in the new thing in the market right now. We do not have enough long-term data on that, but I did not buy one when it came out. For the same reason that really this is very similar to baking, grilling, that kind of thing. Very, very high temperatures, extremely high temperatures. And I do not know what kind of polycarbons you produce when you're actually cooking food through that. So I'm waiting on data before I actually buy that thing. I just said no to that. I would not recommend that right now.
So one more question from Mr. Padmanabha. Is A2 milk better over other milks?
I'm sorry, what was that?
A2 milk. I don't know what is A2 milk.
I'm sorry, but I don't know what that kind of milk is. But like I said, all these differences pretty much are very minute. The data on dairy is not very good. All right. Any kind of milk, 1 glass a day is considered okay. Soy milk, goat milk, people do all these kinds of milk. It's a scam industry for the most part. We have not really seen. I know if you have a certain condition, like a GI condition, that gets worsened when you have a certain kind of milk, that makes sense that you avoid that. Gluten allergic people and all that, you can avoid that stuff. But from the cardiac standpoint, I cannot say that one milk is proven to be better than the others in terms of like cardiac outcomes.
How about organic and processed milk?
Processed milk is never that great. Organic, better.
Okay. So I think this will be our final question. Can you suggest some good snacks that give less calories and are good to heart for people who are getting hungry quite often?
Oh, yes, that's me. So I probably typically do that. Like I said, I have a lot of like snacks with nuts on my desk. So I do have unsorted though, all right? Now, if you actually sort your nuts, then you're just kind of killing the whole thing. So I would say you should probably snack on things like nuts, fresh greens. So a lot of times, Giant Eagle and all these places, we have some green peas, all right? So there's something that they sell at Sam's Club that's called as the snap peas. Those are considered very good to snack on. Those are crunchy. They give you your diet fiber that you need for the day. And they have a little bit of a mildly sweet taste to themselves too. So they're very good snacks. You can eat the multi-grain chips, all right? Don't get the potato chips, but the multi-grain chips that you can get at Sam's Club, Giant Eagle, Costco has a very good thing. I use that, all right? I recommend that to all my patients because they're made out of like flaxseed and fiber. So there's nothing bad in there and they're not deep fried. All right. So that's actually considered good. Unsalted though, please.
So we have one more. I think this is the last one. So So this is from Mr. Vishwa Rajagopalan. Can you please say what grilling temperature is bad? Also regarding fruits, if we squeeze fruits and drink without mixing anything else, is that okay?
Yes, you use fruit without mixing anything. I think that's the way to go. Eating the whole fruit with the fiber, with the sugar, everything together is good. When you just get rid of the fiber and only squeeze juice out of it, then you're only getting carbohydrates out of it. The fiber is gone. So we do not recommend eating things just in parts. Now, about the question on grilling temperatures, I do not know that anybody knows this thing out there. We just know that it's not good. All right. So they have seen that, grilling very often is not good. About certain grilling temperatures, I do not know that I can answer that question, or anybody has a recommended cutoff for that. If there is, I do not know that. So,
thank you, Dr. Hegde. That's so wonderful, wonderful. So, can you please unmute and then give him a big round of applause, please?
Thank you.
Yeah, thank you.
Thank you so much, Dr. Hegde.
Thank
And
you.
Thank you so much, Dr.
Thank you
Hegde.
very much.
Awesome session. It was so
Wonderful.
good. Thank you.
Excellent presentation.
Yes. Hello.
Thank you very much, Vinayak.
Most welcome. I try to keep it to South Asian, so the food and everything, it's kind of like, this is what you guys want. And I really encourage all of you guys, if you donate for a good cause, donate for studies, research studies for us South Asians, all right? Because 20 years from now, 30 years from now, our kids will be in the same boat, where they are looking at things that we do not have enough data on ethnic people. For the first time in 2019, they said South Asians are different from the others. And I want this group to be studied better, all right? So let's look forward to that.
Awesome.
Thank you so much again. It was an awesome
Thank you, everyone.
Right,
Thank you for participation. Okay.
Thank you, Charles, for